Good morning, everyone. We are so glad that you can be with us this morning. My name is Sarah Hatch, and I'm one of the social workers here at Sanders Brown Center on Aging. And I'm joined this morning by my colleague Kelly Parsons from Sanders Brown, as well as Meredith Plant from the Alzheimer's Association, and Regina Goodman from the Bluegrass Area Agency on Aging and Independent Living. And together, we are all so glad that you could join us this morning for our Dementia Caregiver Workshop. Thank you for being flexible as we had to shift completely to virtual this morning. We hope that you're all nice and warm this morning. A few reminders before we get started. We are recording this program, and I'll be emailing out the speaker's PowerPoint slides as well as links to the videos once we get them posted online. We ask that while the speakers are talking that you keep your camera and your microphone off. We'll be monitoring in the chat the whole time, so please feel free to use the chat. And then after each speaker is done, they'll ask for questions. And that's a time you can unmute and ask a question if you would like. So without further ado, we are excited to have Dr. Gregory Jicha with us this morning. So Dr. Jicha, I'm going to hand it on over to you.
Very good. Thanks, Sarah. And thanks, everybody, for joining us virtually for this today. Hopefully, everybody is staying warm and staying safe. So let me see if I can get some slides up and running here and see what we can do. So today I've really been tasked to review the basics of Alzheimer's, and we'll touch on related disorders, vascular cognitive impairment, Lewy body disease, frontotemporal dementia, overall, and really some practical information, not just what is the disease, but how is it evaluated, how is it treated, what are our options, and I think that that's really important, and we'll set the stage for further presentations, hopefully throughout the day. So I'm going to start with, what really is the most common question that we get in clinic and whenever we're presenting to groups in public. What's the difference between Alzheimer's and dementia? And sometimes we do use the term dementia, but it's really a non-specific term. It's really an umbrella term that really just describes what you may be experiencing in yourself or in a loved one. That there's something going on with your brain or their brain, and there are impairments in different aspects of cognition. So that's sometimes memory, but sometimes other domains, language problems or geographic orientation problems. It does not imply an etiology or a diagnosis. So if any of you have been given a diagnosis of dementia for yourself and or your loved ones, it behooves you to ask your doctor, what is the cause of my dementia? That's where we start really drilling down to whether or not it's Alzheimer's or whether it's something else. And there are implications for how somebody's going to do over time and what medicines, approaches, and management strategies we may use. So one of the most important things to keep in mind is that dementia prevalence, the number of people that are going to develop dementia, increases exponentially as we age. So we can see here on this graph that below the age of 65, dementia is much less common. It certainly occurs, and it's very important and with consideration. But as we age, approximately every 5 years, our risk for developing a dementia doubles. And so really, really important. And it can be quite common by the time someone reaches their mid 80s. One out of every two people may have dementia, and that's important. So there are a few barriers to diagnosis, even a vague diagnosis like dementia. Frequently, our patients are unaware of symptoms. I hear families all the time say, "Oh, they're in denial that they have a memory problem." Frequently, they cannot see the memory problem. It's up to us around them to recognize it and to get them help. There are thoughts by many practitioners out there. The first place to address a memory question or concern or another cognitive concern is with your primary care doc. And sometimes we see their eyes roll. They know that this may be very time consuming and not well compensated financially. And then back to the general public, a general belief that memory loss and cognitive decline is a part of normal aging. We may slow down a little bit in the speed of our thought processing, but it should be intact no matter how old we get. And a general belief by many physicians and the general public that Alzheimer's disease and other forms of dementia are not treatable, and nothing could be further from the truth. We'll talk about that today. So let's take a look at the disease course. So here on the x-axis, we have years from diagnosis. And on the y-axis, we have a common memory test called the MMSE here. And we can see if you're a 30, you scored perfectly. There's not likely a memory problem. If you scored a 0, we're running into big trouble. And as one starts to develop cognitive symptoms, there can be a delay. That delay could be a couple years, actually, before an eventual diagnosis is made. This is lost time. And so getting a diagnosis as soon as possible really arms a person and allows them to be the most proactive that they can be in managing their disease. As the disease progresses over a few more years, we might see a loss of functional independence. I need somebody to help with my medicines. Driving is an issue, finances, and we can see the emergence of behavioral problems. These may come earlier than what's shown on this diagram, and we'll talk about those as well. And eventually, a person will progress over the course of 6 to 8 years to a point where they may need 24/7 care. Here it's listed as nursing home placement. We do know that many people choose to care for their loved ones within the home. That's perfectly fine. That's really just meant to be, they can't be left alone. They need 24/7 oversight. And then it is commonly underappreciated and often not discussed or addressed with patients that the degenerative forms of dementia, like Alzheimer's, Lewy body, frontotemporal dementia, are universally fatal. Eventually, after 10 to 12 years, that could be even a couple decades, and some, if it's slowly moving and we're maximizing therapy. But eventually, until we have a cure, these diseases all eventually result in a loved one passing. Now, when it comes to memory and thinking, I mean, that's great. I value my memory and my thinking. But what's really important is what's shown on this slide. And so here we have on the x-axis that MMSE score between 30 to 0. Here we're just showing 25 to 0. And then we see activities of daily living. This is what I really care about. I care about the function in an individual patient. So we may see, even when they're still scoring pretty good, a 24 maybe on their mini mental, there may start to be some early difficulties in keeping appointments, using the telephone, obtaining a meal or a snack. And that can progress over time by the time one's mini mental score is between 15 to 20, we may see people beginning to develop difficulties using appliances, finding things in the home, even picking out their own clothes and getting dressed. And over time, that can progress as the disease spreads in the brain. And we'll talk about that. Eventually, one can essentially forget how to walk. And lose the desire to eat and drink. And eventually, this is all part of what eventually may lead to a loved one passing. So, this is a big problem, and sometimes when you're affected or your family member's affected, there's a tendency to think I'm alone in the world. Nobody else is experiencing this, but the problem is huge. So on the left, we see this green circle with a yellow piece of pie in it, and that yellow piece of that green pie is the population in the United States, about 13% over the age of 65 years of age. That's one out of every six people in that age group. And then if we look at how many of them have dementia, that's shown as the red pie slice, we see that 13% of that 13% actually carry a diagnosis of full-blown dementia, meaning cognitive problems, memory or thinking problems that are severe enough to impact somebody's daily function. And that number is quite high, approximately 6 million people in the United States. But we also know that you don't go to bed one day and wake up the next with dementia. Instead, there is a slow progression. And so we can look at when somebody who is normal begins to develop a decline in memory and thinking, a decline in cognition, but they're able to compensate using sticky notes and GPS on their cell phone. They're able pill boxes. They're able to compensate. That then creates what we call mild cognitive impairment. They're maintaining their function, but they're starting to have some trouble. And only as that cognitive problem gets worse do we see the decline in function that takes us to dementia. So, this area of mild cognitive impairment is very, very important for early recognition of a problem, planning, and treatment to try to slow that disease progression. When we start looking at the number of people in the United States with dementia or mild cognitive impairment, we can see that that number doubles to 12 million. That's 30%, one out of three people over the age of 65. You are not alone. That's important. Now, there are many different causes of dementia. We talked about that umbrella term. So we have the neurodegenerative conditions, Alzheimer's. I've listed the big four: Alzheimer's, frontotemporal dementia with Lewy bodies, and vascular dementia. But there's dementia associated with Parkinson's disease. There are many other forms of dementia. And of course, there are many non-degenerative causes, and these are critically important for us to understand. We may see somebody who has memory and thinking problems impacting their function, and so they meet the criteria for dementia, but it's because of excessive drinking, or they're on medications that are impairing their memory and thinking, or their thyroid's out of whack, or they have a vitamin deficiency. And so the medical workup is really designed to look at these, and these can be quite common in the population. Up to 30–40% of people that begin to experience memory problems may have one of these medical fixable issues. And that's really, really important. So How do we know if the slowing that is in our thinking speed that is part of aging is a real problem or not? Well, there are many tools that have been developed. And so this is a simple, what we call the AD8 screen tool. And if you answer yes to two or more of these questions, there's over a 90% chance that there is indeed mild cognitive impairment or dementia that warrants a workup. So let's walk through these. The first is, does your family member have problems with judgment, problems making decisions, bad financial decisions? And remember, we're looking for a change from their previous abilities in these areas. So somebody that's always made bad financial decisions, we would not say that they're having dementia because they continue to do so, but somebody who's always made good decisions in the past, starting to make bad decisions, might fly a flag for us. Is there less interest in hobbies and activities? This is what we call apathy. Very, very important early indicator of of a potential impending memory problem, MCI, or dementia. Repeating the same things over and over again, especially over a short period of time. Trouble learning how to use a tool, appliance, or gadget. Forgetting the correct month or year. I always give people a little bit of leeway. They're retired, and if I ask them, what's the date today, and they tell me, I don't know, it's 27th or 28th, we're somewhere in that area. I'm perfectly fine. If I ask them what day of the week it is and they tell me, I think we're getting towards the middle of the week, it's Wednesday, when we know it's really Tuesday, I'll give them a little leeway. But like the patient I saw yesterday, if I ask what month it is and they tell me it's July, when we're all wearing winter clothes and there's snow on the ground, I know there's a real problem. Trouble handling complicated financial affairs, beginning to have difficulty balancing the checkbook, paying bills, trouble remembering appointments, and general daily problems with thinking or memory. So again, these 8 questions, if a person answers yes to two or more of them, they really need an evaluation. So there are a few other symptoms that can be associated with the memory and thinking problems that we should all be aware of. The memory circuits in the brain are part of the emotional circuitry of the brain. And so, as we develop some weaknesses in our memory and thinking abilities, we can see a loss of our ability to manage stress and control thoughts of depression and anxiety. And so, really, really important to look out for these. We can see behavioral changes, personality changes, inappropriate behaviors. Sometimes these are prominent features in frontotemporal dementia, but we can see them across all forms of dementia. We can see hallucinations. People who actually see other people or animals are very, very common, or delusions. I think my wife of 60 years is having an affair with the pastor. I and sometimes we can think about Lewy body disease, but this can happen in any form of dementia. We like asking about sleep disorders. Sleep disorders can be associated with dementia. Some sleeping problems, severe obstructive sleep apnea that's untreated, or insomnia, in and of itself cause memory and thinking problems. And then we're always looking for Parkinsonism. It may not be overt Parkinson's disease, but slowing of movement, shuffling of walking, the beginning of tremors, that can be diagnostic clues for us or things that we need to treat. And we look for focal deficits. Have they had a stroke in the past? Is vascular disease contributing here? So it's not just memory and thinking. So once we determine that we have a loved one who, or we ourselves, may be having a memory problem, you go go to see the doctor. That's what you should. And you should get a memory screen. This is a typical memory screen called the Montreal Cognitive Assessment. It's got pictures of cute little animals on it and a series of questions. And this can be really, really good. But it takes about 15 minutes or so. So sometimes your primary care provider may not have the time in a routine appointment to go through this, in which case you may want to ask, can we come back and address just the memory problem? And try to do that in a timely fashion. Certainly, expert memory clinics like the one that we run will routinely test one's memory and thinking. And then we look for other things. Of course, we want to listen to the heart with our stethoscope, and we're looking for other medical causes. We're hitting everybody with a rubber hammer on their knees to check their reflexes, looking to see how strong they are, how they walk, and many other signs and symptoms. Part of the workup for somebody with memory problems also includes getting a picture of the brain. And CT scans are really used only for those that have implanted metal in the body and can't have an MRI. An MRI is much better. And we can look at the size and shape of the brain. Very, very important. All of our brains shrink as we age, and they normally shrink like a balloon that you let air out of. They shrink uniformly all around. But in different degenerative diseases, we may see different patterns of shrinkage. So in the upper left, next to the healthy control, we can see the shrinkage in the brain of somebody with Alzheimer's disease. And I hope you can see these areas that I'm trying to circle here. These are the memory areas of the brain, and there is a lot of shrinkage here compared to the shrinkage in the other parts of the brain. This is a pattern that is very diagnostic for the potential of Alzheimer's disease. The MRI also lets us understand if there's a brain tumor, if there have been strokes, or if there's a buildup of spinal fluid in the brain. And again, different patterns of shrinkage are shown in the lower right for different forms of frontotemporal dementia. And the important thing is to recognize that these patterns, how these brains look, are very, very different. And so we may have that umbrella term of dementia, but the imaging gives us a glimpse into where are we losing nerve cells, what's causing injury to the brain, and in doing so can guide our diagnosis and treatment. Now, this is just a slide looking at those memory areas of the brain. And on the far left, we see somebody with normal memory and thinking at age 25. And outlined in red is their memory area of the brain, big, juicy, and plump. As we reach the age of 75, even with normal memory and thinking, we can see some shrinkage of those memory areas. But if we develop mild cognitive impairment or Alzheimer's disease, the shrinkage is severe. And this tells us that we're preferentially losing nerve cells in these memory areas and that Alzheimer's may be a leading cause. There are times when we may want to get a special scan of the brain. This is what's called an FDG PET, fluorodeoxyglucose. So basically radioactive sugar injected in the vein, and then we see how the brain is using sugar. And the brain is really amazing. It uses about a third of the sugar that we eat. So if any of you had a donut this morning for breakfast, a third of that donut is in your brain right now, two-thirds of it for the rest of the body. So the brain is very active in its use of sugar. And we can see a normal brain lighting up in red and yellow. Whereas an Alzheimer brain on the right, we see very few areas of the brain actually using that sugar and lighting up. It tells us that the nerve cells are very sick. And we use this sometimes to differentiate Alzheimer's from other degenerative forms of dementia, like frontotemporal dementia. More recently, Amyloid PET scanning has been developed, and we use this quite commonly in practice when we're entertaining some of the new medicines that we'll talk about. We've had this for about 15 years now out there, FDA approved, but only recently has Medicare decided to pay for these to identify whether or not somebody has Alzheimer's in the brain. And so you see the colored scans up top, and down below is a diagrammatic representation of the spread of Alzheimer's in the brain over time. And so, what the amyloid PET scan can see is exactly what an autopsy would show us. It can show us the actual plaques and tangles in the brain. And that's really, really important. Sometimes we may use spinal fluid to detect Alzheimer's disease, and this is not a major issue. Most of the time, it's done in the doctor's office, and our clinic takes about 15 minutes or so, like a blood draw from the lower back. And that is just as effective in not diagnosing dementia, but in diagnosing Alzheimer's disease. And spinal fluid can also be used to diagnose Lewy body disease. So that's really, really important. So let's switch to some of what causes the major problems for many folks with any form of dementia and their family members. And these are the behaviors that can be associated with dementia, not just short-term memory loss, but this lack of initiative, this I don't want to do all these things that I used to enjoy, these emotional changes, depression, agitation, anxiety, resistance to care. I don't need your help with that, even if they do need your help. Wandering and pacing. I want to go home, even when they're in their own home. Shadowing that's following you around where you can't even go to the bathroom by yourself. Hallucinations. Change in sleep patterns, rummaging, hoarding, sometimes yelling or combative behaviors. And we think about that, and there's a tendency to think, well, this person is just creating trouble. But it is important for us to remember, no, this is part of the disease. So these symptoms can be quite common. And I love this chart. The red line at time zero tells us when a person is diagnosed with dementia or Alzheimer's disease or other. And we can see here that up to 3 years before that diagnosis is made, we see 40% of people withdrawing from social engagement and activities. 2 years before the diagnosis, one out of every two people are experiencing depression. And within a year after diagnosis, we can see up to 80% of people experiencing some shortening of their temper, agitation. People often describe this as, well, they're meaner. And so behavior can be affected in the vast majority of patients. And again, it's not our loved ones behaving badly on purpose. It is the disease invested in what we call the limbic system. So we can see the memory areas of the brain in green here, and those are widely connected with the limbic cortex for mood and the amygdala for emotions, fear, and anxiety. And as the disease spreads throughout the limbic system, all of these areas can be involved, and they create what we call the behavioral and psychological symptoms of dementia. They're very problematic, associated with about 30% of the cost of caring for somebody with Alzheimer's disease, strongly associated with caregiver, family member depression, institutionalization, skilled nursing placement. They can undermine our ability to provide care. And this is important. As we see these behaviors, our own responses can feed into a vicious cycle where things just get worse. So it's important if we're experiencing any of these behavioral and psychiatric symptoms of dementia that we first take a look at why. What could be the trigger? Maybe our loved one is thirsty. Maybe they're hungry and maybe they can't express that. Maybe they're in pain. Many times, abnormal behaviors can respond to a Tylenol test. Give them 2 Tylenol and see if their behaviors diminish. If so, their arthritis or back pain may have been the cause. Distress, feelings of abandonment, and fear. And if we can understand those triggers, we can be preemptive. We think about environmental factors, excessive stimulation, too many people. We see this frequently at the holidays where the whole house is changed with all the decorations, and all of a sudden we got 30 people in there. Our routine is disrupted. There can be inadequate lighting, dark places in the house that we can't fully see, and that they become a mystery. What's lurking over there? Confusing surroundings. We always say, when you develop a memory problem, that is not the time to rearrange your furniture or to go overboard in your holiday decorations. Try to limit the change. Excessive demands, trying to force somebody to do things that are beyond their current abilities. This can also lead to agitation, frustration, anxiety, and importantly, for us to self-reflect. What are our behaviors? What are the behaviors of the others in the home? One person who's anxious and agitated will be mirrored by our loved one with dementia, and they will start to become anxious and agitated. If we're calm and reflective, so if we sense that we're starting to get a little frustrated, it's a good time to take a few deep breaths and say, all right, I need to model calm, anxiety reducing behaviors. Very, very important. So there are times when we look at what those causes are and we can't figure it out. And that may be a time to bring somebody to their doctor. Where we can take a history. When did the behaviors start? It's very good for you all to take notes on this. When do the behaviors occur throughout the day? Which days do they occur on? What's happening those days? We want to look at these environmental changes. We also want to think about contributing medical problems, in infection. I have a patient right now in the hospital who was developing very agitated behavior, and they were brought in, and it turns out that they have a pneumonia with a fluid collection around the lungs. And with treatment, we may be able to resolve not just their respiratory problems, but some of the agitation and behavioral changes they've been experiencing, urinary tract infections, and then always think about intoxication. I always say, I had this super sweet young lady. She was about 85, and she liked to have a small glass of bourbon every evening. Her daughter dropped her off a new bottle of Maker's Mark, and the next day when mom wouldn't answer the telephone, she ran over to her house and found her mom on the floor with a head injury from hitting the coffee table, needed about 20 stitches or so, and that bottle's of Maker's Mark was completely gone. Alcohol and dementia just don't mix, because every drink is your first. And so this young lady, with all good intent, just wanted to have her one bourbon in the evening. But after having one, she forgot she already had it and had another and another and another. This can be a problem. And then we think at prior psychiatric history as well. Maybe these are things that have always been there and they're just coming out now. We also think about the side effects of medicines. And so your doctor and or your pharmacist, and your pharmacists are a great resource to ask about these sorts of things. Which medications are we taking? And don't forget to talk about over the counters. So some of the anti-acid medications have anticholinergic properties. They make memory and thinking worse as we age. Antihistamines like Benadryl and over-the-counter sleep aids, many other medicines that a doctor may prescribe that we don't think about potentially having effects on memory and thinking because they're used for something else, do have memory and thinking worsening as one of the side effects. So, really important to look at those medications. So, what are we going to do to treat? Well, we're going to be good caregivers, right? We're going to provide a structured, secure, safe environment. We're going to maintain our routines. We're going to engage in constructive activities and social interactions. Sometimes, we don't ask somebody, would you like to go to the best friend center today? Instead, we say, come on, we got to go, and we get them in the car and we drop them off. We certainly need to attend to medical and physical conditions. We have to support the caregiver. So, for those of you out there that are sole caregivers doing it 24/7, please get some help. You need to be supported as well. And then we need to make sure that our loved ones are getting ample sleep and that the caregiver is getting ample sleep and nutrition. And if we need to treat, the first rule of thumb is treat the dementia first. So hopefully everybody's been to the doctor, gotten their diagnosis, and then we can begin treatment. So other things that you can do at home, try to distract or redirect. You can't argue with a patient. If they want to go home, trying to convince them that they're already in their home is not going to work. We might choose a different tact and say, well, it's really late tonight and there's a lot of ice on the road. We'll go home. We're just going to stay here tonight. We'll go home tomorrow. By the morning, they'll have forgotten about it. We want to adjust the environment, right? If you're having a holiday get together and two of the family members start fighting and arguing, throw them out of the house. Tell them that they can come back when they can behave calmly and respectfully. This is not going to be good for your loved one with dementia. Provide that structure and consistency, avoid overstimulation, and plan activities. Speak clearly at a steady pace. Keep your language simple. Engage eye contact. Show warmth and firmness. Address by name. Reinforce who you are. Use nonverbal cues. I'm a big toucher. Holding somebody's hand, putting your arm around them can be incredibly reassuring and comforting. And use your common sense to figure out what you should be doing to keep your loved one doing well. So let's just summarize what should happen. Once we recognize, yeah, there's a potential memory problem that we need to look into, you should address with your primary care doc, and they may do a brief examination and determine if there's a problem. They may refer you on to a memory specialist. We can send people for more extensive memory and thinking testing, although most of the time that's really not necessary. We do need to do a medical workup. We need to look for those medical causes before we jump to a diagnosis of Alzheimer's or something of that nature. We want to make sure there's not a simple medical problem that we need to fix. We want to get that picture of the brain. When we're done with that, we may be able to establish a diagnosis of dementia, define the type of dementia, perhaps send people for one of those other scans or spinal fluid. And then once we understand what is the cause of the dementia, we can proceed with treatment. So let's talk about Alzheimer's disease, pathology. This is an autopsy of someone with Alzheimer's disease, and there's a lot of shrinkage of the brain. And there are two key features to this that were described by Alzheimer's in the early 1900s, well over 120 years ago. The amyloid plaque, which exists outside of nerve cells, and the neurofibrillary tangle inside nerve cells. And both of these are toxic to the brain. So, really important. So, I think I have to redo. I'm stopping my share and I'm going to reshare here because I do believe that I've got to share sound for this to work. So let's see where we are here. And if we can go back to where we were, we'll watch a brief video. Interrupt me if you can't hear the sound.
Alzheimer's disease was described for the first time in 1907 by the German psychiatrist Alois Alzheimer. In performing a histopathologic study of the brain of his patient Auguste D, suffering from dementia, he brought to light the presence of two types of lesions in the brain, senile plaques and neurofibrillary tangles. He reached the conclusion of a distinct disease of the cerebral cortex. 100 years later, thanks to current scientific techniques, research has made a great leap in the understanding of the disease. We know that the brain is made up of neurons and that these are interconnected to form a vast network. These connections, known as synapses, enable the transmission of information from one neuron to another. In Alzheimer's disease, 10 to 15 years before the appearance of the symptoms, two main lesions form in the brain: senile plaques, composed of amyloid beta protein, and neurofibrillary tangles, composed of tau protein. How is the senile plaque formed? On the surface of the neuron is a large protein called APP. Normally, APP is sectioned by enzymes on the surface of the neuron, and it frees a protein called amyloid beta. The amyloid beta protein is then cleared in the body. In the case of Alzheimer's disease, there is an imbalance. The amyloid beta protein is no longer regulated and is found in too great a quantity. The proteins assemble to form indissoluble fibrils and create senile plaques. How are neurofibrillary tangles formed? When a neuron communicates with another, a signal goes from the body, known as soma, to the synapse to transfer the information. The signal passes through the skeleton of the neuron composed of microtubules. These microtubules are stabilized by normal tau protein. In Alzheimer's disease, tau protein becomes defective and detaches from the microtubules. Thus, the skeleton of the neuron dissociates as it is no longer maintained. Defective tau proteins then assemble to form filaments in the neuron. Without the skeleton, the neurons degenerate and connections between the neurons are lost. The abnormal accumulation of tau filaments in the neuron creates neurofibrillary tangles and eventually causes the death of the neuron.
So we'll move on, but now you guys know everything about Alzheimer's disease, and we're using that as the prototypical example. Now, there are genetic influences on Alzheimer's, but as you appreciate on the left here, True genetic Alzheimer's is incredibly rare, less than 1% of all cases. There are only 500 families in the world. These people tend to come down with Alzheimer's in their early 40s. So most of our folks that are developing memory and thinking problems are developing them later in life, age 60 and above, as we saw with age being that risk factor. And there are some risk genes, but they're not absolute. The big one is called ApoE4, and those risk genes interact with other environmental factors. So Alzheimer's can run in families, but again, it's so common with 1 out of 3 people over the age of 65 that having it in your family does not mean that there's a strong genetic linkage or that other family members are destined to develop problems as well. But having a first degree family member, a father, a mother, a brother, a sister, or a child with Alzheimer's disease increases a person's risk. We usually don't look at cousins or aunts or uncles. It's really your first degree family members. So let's take a look at ApoE. ApoE is what's called a risk factor, the most common risk factor. And I like to say this is like the chubby gene. I got the chubby gene from my mom. It makes me want to carry around a few pounds, extra pounds. Now, do I have to? No. And I was like saying when I was looking for a wife, I was at the gym every day. I was buff. She looks at me now and says, "What happened to that washboard tummy?" And I always tell her it's still there. It's just washboard for the delicate cycle. So if we look at this, we use squares as men and circles as females. We see great grandma and grandpa, and great grandpa has the ApoE risk gene and develops Alzheimer's and passes that gene to one son who has the gene but never develops Alzheimer's, and passes the same gene to a daughter in red who actually does develop Alzheimer's. And so we can see the gene being passed in those that are pink or red, but Alzheimer's causing memory and thinking problems only in the red areas. Now, this is not like witchcraft. It doesn't skip a generation, but the gene itself is not definitive for diagnosis. We do test the gene for some of the new Alzheimer medicines so that we understand a person's risk. But this is the basis for why we see Alzheimer's in families. So I'm going to switch gears now and broaden this because we've talked a bit about Alzheimer's disease, some of the other behavioral symptoms, the initial workup, the same across all degenerative diseases. But we do realize that Alzheimer's is only about 50 to 60% of the causes for dementia. And so there are many others. These are just 5 different, studies out there showing they all show the same thing. And so these are the big 4: Alzheimer's, vascular dementia. There may be strokes or maybe just hardening of the arteries, dementia with Lewy bodies, which is a cousin to Parkinson's disease, and frontotemporal dementia. And there are different criteria, and we won't get into the nuances, but sometimes we will see with vascular dementia, the MRI can be very, very helpful for us to look for vascular injury of the brain. For Lewy body patients, there's a tendency to develop some Parkinsonism and early hallucinations. And for frontotemporal dementia, prominent behavioral or language difficulties. And so when we're looking at cases very early on, the pattern of impairments, so yellow for cognition, orange for language, red for psychiatric, white for behavior, and green for motor symptoms, is very, very different across these 4 types of dementia. And as the disease progresses to the mild stage of dementia, we see more and more symptoms emerging. And as we reach the moderate stage of disease, more and more symptoms emerging. And eventually, in the later stages of disease, all of these degenerative diseases impair all aspects of brain function, and we can no longer tell the difference between the different diseases. So it's important that we get that early diagnosis when it's much clearer what's driving the bus. Now, in the later stages of disease, we need to be prepared. We can start to see seizures. Very rarely is it shaking, foaming at the mouth, Hollywood type seizures. But more often, behavioral unresponsiveness, staring episodes, unusual repetitive behaviors. We can see incontinence, and this can be a major problem for managing the health and well-being of a loved one. We can see difficulty with motor function, stiffening of the muscles, trouble walking. We can see contractures, and folks eventually can develop a fetal position, lose the ability to speak, and become bedridden. So let's switch gears in the last few minutes and talk about treatment. So this is an algorithm which I teach to all the medical students and other doctors, and that is talk to your doctor about the different symptoms and try to figure out what's the biggest problem that I have here, because we can't fix everything all at once. And so is it the cognitive issues, the memory and thinking? Is it the behavioral issues? Is it the psychiatric issues? Are there motor issues that we need to address? And set up repetitive visits so that we can stay on top of these and move on to the next. So we have some very good medicines for all the different forms of dementia. So we have 3 types of what we call cholinesterase inhibitors, and they're all virtually the same: Aricept, Epazil, Exelon, rivastigmine, and razidine galantamine. They all do the same thing. The rivastigmine comes in a patch, and so for people that are sensitive to these medicines, and the major side effects are nausea, upset stomach, a loss of appetite, and diarrhea. If one has GI symptoms, then we may not be able to use a pill form. We frequently can use the patch, and the benefit is sustained over time. We also have another medicine, a different class, called memantine or Namenda, and this is very, very helpful and can be used in combination with the cholinesterase inhibitors. So these are very simple medications. They're generic. So this is, again, years along the x-axis, and the Montreal Cognitive Assessment Score from 0 to 30 on the y-axis. We see that slope of decline over years for somebody. And if we treat them with a cholinesterase inhibitor, it doesn't stop the disease. It doesn't cure the disease, but it slows that rate of decline. And if we add both medicines, we get an even greater slowing of disease. But you'll notice a few things. You'll notice that we still end up in the same place. These are not cures. But in the meanwhile, at every step of the way, we could say, do we want to be on the green line, the yellow line, or the red line? Well, that green line looks pretty good to me, and that's where I want all my patients. So very, very important to do our best to try to get people on these medicines if we can at all possible. It will help to preserve their function, delay the need for 24-hour supervision, although the disease course will remain the same. So what else should we do? Well, what about lifestyle modifications? Yes. So keeping somebody stimulated cognitively with activities. We certainly want to manage blood pressure. We want to increase physical activity and exercise. 20 minutes of exercise 3 to 5 days a week is sufficient, but we really need to do this. And we also think that a healthy diet and social activity are important. They've been very difficult to study, but we do have evidence for them as well. We finally have entered this new era of disease modifying therapies. And this is really, we've been working on these, for 25 years, but really over just the last few years, and really since 2023, have we had full FDA approval. These are medicines that can actually remove the amyloid plaques from someone's brain. So we have two different medicines that have been approved, lecanemab and donanemab, which are Leqembi and Kisunla. And we figured out which doses work, and these will slow the disease by 27 to 40%. The earlier we get somebody on these medicines, the better the benefits are. Some of the latest studies suggest that 5 to 7 years out from initial diagnosis, if we get somebody at the very earliest stages of mild cognitive impairment, they may be doing the same or even better 5 to 7 years later. We've never seen that with Alzheimer's before. Very, very important, though. With these medicines, there are potential risks. And the picture on the bottom right shows this white in the brain. This is a buildup of fluid and edema. We've clogged all the blood vessels trying to remove those amyloid plaques. And so we watch for this with MRI scans. And so these medicines are only available to folks that could have an MRI scan. There are several medicines. We've learned a lot about this. We've learned which are safe and which are effective, and that's led to the two current approvals. Again, the slowing of disease, maintaining people on these medicines for years, can buy years of extended life and years of quality of function. So once we get people on the symptomatic medicines, we want to move to these. The medicines are not for everybody. And if the disease has progressed too far into the moderate stage and the memory and thinking test scores are too low, the medicines will no longer help at all. And so all we have are risks. And so the medicine cannot be prescribed, and Medicare will not pay for that. We do need to do a PET scan or a spinal tap to collect spinal fluid to prove that the disease is actually Alzheimer's. And there are other MRI concerns for those on blood thinners. And so really, really important. But Medicare is paying for this. Some folks can have a copay, but this is really the first step towards curing the disease. And right now, there are well over 100 different new potential treatments that include possible cures that are in experimental therapies. Once you've gotten your loved one on everything that you can do, if you're looking for more, this has a possibility. The newly approved medicines, just approved in 2023, we were giving people 12 years earlier in 2011 here at the University of Kentucky. So the first person to be cured of Alzheimer's will be cured in a clinical trial. There is no doubt about that. Long before the medicine is available in a routine doctor's office. So please think about that. Get involved today. And with that, I'm going to stop. I made it under an hour, but I don't know how much time we have for questions. But again, at our program lead's discretion, I'm happy to open it up to questions if folks have any. I know that's a lot of material to cover. You should have a copy of the slides and the handouts from today that you can go back to and refer to as needed.
We do have a few minutes. We can take a few questions.
I have some. Um, my name is Taylor Cobb. I'm with Bluegrass Area Development District, and I know we have just a little bit of time, so I won't go through all of these. But I did have your presentation was very, very, very informative, and I loved it. Um, I guess I had several questions, so I guess um, one of them was, and I could have missed it, but does Down? I work with Medicaid people with Medicaid disabilities. Does Down syndrome and autism have any type of links of Alzheimer's disease or dementia type diseases in the future? Because you did talk about neurodegenerative diseases, and I don't know if some of them affect the brain or not, but I do know that some of them are, mentally, delayed.
Yeah,
So I was just curious
that's
about.
yeah, that's a great question. And yes, we'll take Down syndrome first. Down syndrome is also called trisomy 21. There are three copies of the 21st chromosome, and in these folks, and that is the chromosome that has the amyloid gene on it. And so all folks with Down syndrome make almost twice as much amyloid as the regular person. And so almost universally, by about the age of 30 to 40, all Downs patients will have a brain full of amyloid plaques. And some may escape the clinical form of disease, but well over 90% of Down syndrome patients, by the time they reach the age of 60, if they live that long, will indeed have Alzheimer's disease. So very, very common. The question about autism is a little more complex. Here at the University of Kentucky, we are one of the world's leaders in this area, and we have noticed that many of our dementia patients develop autistic behaviors. And
Wow.
that began to draw a link between these. And it's quite interesting. What we have a tendency to see is that those folks with autistic behaviors are more likely to be male. The exact same thing is seen in children with autism. It is more common in males, and they tend to have an onset at a much younger age. So this does suggest that there may be a link, but autism is not just one disease; it's a spectrum of disorders, and a
Yeah.
lot more work needs to be done in that area. But as a general rule, anything that injures the brain or that causes brain dysfunction will increase your risk for Alzheimer's. So, for most of us, we're thinking about head injury, meningitis, encephalitis, prior strokes, and the like. But some of these developmental disorders certainly will increase a risk for dementia later in life, often with a much younger onset than we would see otherwise.
Oh, okay. Can I ask one more too? I know the other type questions, so I just have one more. Um, if you were to get dementia, I saw like where dementia was the umbrella, and I saw the different cases of the styles of how you can get them. I know this is kind of like a weird question, but if one was to get this disease, which one would they want? As far you know how people say, if you were to get cancer, uh, prostate cancer would be the one that you would want. Does that make sense? So which
Yeah, yeah.
awesome,
I, Well, the answer overall is you don't want any of them.
right?
But it is an interesting phenomena. Many times I'll see a patient and they will tell me, my doc says I have dementia. I don't have Alzheimer's disease. And even if they do have Alzheimer's disease, I don't correct them. If it makes them feel better to think that they don't have Alzheimer's, I'm great with that. I have found of all the diagnoses, when I tell people that they have vascular dementia, they're typically very happy with that. Well, thank God it's not Alzheimer's disease. There's a problem with that. And the problem with that is that while vascular dementia can, in some cases, evolve incredibly slowly, in the overwhelming, the average case, the decline is much more rapid than in Alzheimer's disease, and death comes several years earlier. So I don't know why people are so comfortable with hardening of the arteries and vascular disease, but it's not any better, and indeed may actually be worse than Alzheimer's itself. So the important point is not which is a better disease to have, but knowing that there are different ways to manage each of the diseases. And again, in Lewy body disease, we may be focused on some of the Parkinson's and hallucinations that we don't have to address in an Alzheimer patient until much later in the disease. And in frontotemporal dementia, we may be dealing with a lot of behavioral issues, and we don't have to worry about memory and thinking at all. So understanding the disease, no one is better or worse than the other, but understanding the differences in the diseases is really, really helpful for us to keep folks doing their very best and staying one step ahead of the symptoms as we go.
Thank you.
All right, we had one person raising their hand.
Yes, this is Joanna. Earlier in the presentation, there was a slide where you started recognizing certain symptoms. What is the pros and cons actually going over that slide with the person with dementia?
So, well, we always say two things. If it's very, very mild memory problems, sometimes people will have insight, but they do tend to lose that insight. As a general rule, we always say it is not necessarily important that the person with dementia recognizes or admits or fesses up to having dementia. It is important that the family members and those that support that person are aware of the diagnosis. So again, you can discuss anything that you want to with somebody who has dementia. If you start to see them becoming agitated, anxious, you really need to rethink, what am I trying to gain by rubbing their nose in their symptoms? Is that productive? Is that going to help? Or is it just going to alienate them further and make it more difficult for us, those that are supporting them around them, to put in place the safety nets and assistance where we can? So that's a complex question, Joanna, but that's my advice. Frequently we will get pushback the more we push at somebody with look how bad you are, the more that negativeness is going to interfere with a productive relationship where we can most benefit them.
Okay, because I know I'm a visual learner, and I don't know if I ever get to dementia. I was just wondering if my behavior would benefit from seeing me circling all the things that are now identified to dementia. So I was just wondering, based on each one of us learn different, if that would be pro or con to it. Okay, but thank you.
And I have seen folks benefit from that kind of discussion with visual aids, but I've seen many who haven't. So again, it's very individual.
Yes, this is Oscar. I had a question. You had mentioned the glucose that fuels the brain cells and stuff, and I had seen some discussion of research that's going on about the use of ketones to essentially give the energy from ketones that the brain cells are having trouble when they can't absorb the glucose.
Yeah. So really important. I will say, Oscar, you don't sound too grouchy, but that's a great question. So we have done many studies, and years ago there was a big fad of coconut oil and coconut oil full of medium chain triglycerides, a rich source beyond sugar. There are many folks that feel that the sick nerve cells in diseases like Alzheimer's cannot use sugar effectively, and that these alternative nutritional sources may be helpful. We do have some clinical trial data in support, but it is doesn't help everyone, and the benefits can be limited. With that being said, for those that would like to use coconut oil or another source of medium chain triglycerides, look for a healthy source, and I'm perfectly fine with that. It's not going to stop the disease, but again, empowering ourselves to really do everything that we can do to keep the brain as healthy
Can't
and
get on my
powered up as
computer.
possible is really important.
Thank you.
Thank you
So,
so much for the great questions. And Dr. Jicha, thank you so much for taking time to share with us.
Excuse
We're
me.
going to,
I keep getting
yes.
I just got in late and I keep getting unmuted. I mean, yeah. So I don't know why it says that you have unmuted me or muted me.
We
down
do try to
here.
keep everybody muted during the presentations.
Very good. Well, thank you, Sarah, and thanks everyone that came today. I'm going to let you guys get on to the rest of your program. I hope this is helpful. Stay engaged, stay involved with both the Center on Aging and the Alzheimer's Association, the other community organizations that can be so helpful and supportive that you'll hear about today. We can, while we cannot yet cure the disease, we can make this journey tolerable. We can keep a person with dementia smiling throughout the course of their disease, and that is a huge success. So have a great day, everyone. Again, stay warm, stay safe.
That's it.
Thank you so much. No, we are going to take just a quick 5-minute break, and then we will be back at 10:15 for our next presentation.
All right, it is 10:15, and I want to go ahead and keep us on time. My name is Meredith Plant. I'm a program manager at the Alzheimer's Association, and I am so pleased to introduce our next presenter. Not sure what that was, but our next presenter is Cindy Sheriff. She is a community educator with the Alzheimer's Association and has been involved with us for several years. I'll let her share her connection and why she volunteers and gives these presentations to the community. So Cindy, without further ado, I'll get this presentation started and mute myself and we'll get going.
Thank you, Meredith, and welcome everyone to this morning's presentation on communicating effectively. As Meredith said, my name is Cindy Sheriff, and I am by education a behavioral health clinician, been in the EAP and wellness world most of my career, or basically all of my career. So back a few years ago, when my dad started to show some signs of Alzheimer's disease, I knew enough about the brain to know that this disease was chronic and fatal. So I decided I was going to learn everything I could about this disease because knowledge is power. And even though I knew I couldn't change the outcome of Dad's journey, I knew that I could learn as much as I could and implement as many things as possible to make this journey as easy as possible for him. So today I'll be sharing information from the Alzheimer's Association, plus some insights that I had from taking this journey on a personal level. So some of the things that we're going to do today is build a foundation for caregiving. We're going to learn how to communicate effectively, and we're also going to look at some good resources that the Alzheimer's Association has. So let's look at our learning objectives today. Hopefully, after today's presentation, you'll be able to explain how dementia affects communication. We're going to talk about a person-centered approach because when you're caregiving for someone with dementia, no two cases are the same. So everybody needs their own individualized treatment plan, and we call that a person-centered approach. We're going to talk about some strategies, some practical strategies to help you communicate with family, friends, and also care professionals. So first, let's talk about what is communication. So communication is how we tell people about our wants and our needs. It's about how we share our thoughts and our feelings, and it's how we connect with each other. So let's see what we already know, what you already know about communication. So you don't have to answer these out loud, but just in your head, which of the following are ways that people communicate? Talking and listening, attitude, tone of voice, facial expressions, and body language, or all of the above. And I'm sure most of you selected all of the above. That is the correct answer. Communication comes from our words, but there's so much more that goes into our communication. If you think about a small child before they've learned to speak, they can communicate with you. They can let you know what they need through nonverbal communication. And that's what happens as the disease of Alzheimer's progresses. So on our next slide, we see how Alzheimer's causes damage to the brain cells. And the earlier presentation, I think, did a wonderful job of explaining that. I learned so much from it. But these brain changes, as the doctor talked about with the plaques and the tangles, they affect the memory, the thinking, the behavior, and the communication skills. Remember, he mentioned how the brain actually physically shrinks because those synapses aren't sending the neurons the signals? Well, I often describe it in my dad's world as his brain began to shrink, his life began to shrink. His social interaction, his communication, everything around him began to shrink. Now, communication changes are often the very earliest first signs of dementia, and they can be different from person to person. So here are some common changes a person living with dementia may experience. They'll struggle to find the right word. They'll repeat familiar words, phrases, and stories. And they'll go into elaborate detail describing an item, but they can't think of the name, the noun that goes with that item. They might be right in the middle of a sentence and forget what they were talking about. They have difficulty organizing their words that make sense. If their English is not their native language, they may revert to whatever their native language might be. And you'll notice they'll begin to speak less often. And I think this is not because they don't want to, it's just because they have such difficulty communicating their thoughts, and it's so frustrating. They'll also use a lot of hand gestures when speaking. Now, once again, no two people are going to be the same. And I think many times when we start to see some of these symptoms in people, there's a natural tendency to justify it or make light of it and say, oh, they're just getting old. And while some of that is true, mild cognitive impairment can happen to anybody as they start to age. but the disease of Alzheimer's is not a normal part of aging. So we're going to talk now about a person-centered approach. And basically what we're talking about is an individualized treatment plan for your loved one. This means that you know what that person is like. You know how they like to.
This is Meredith. I think Cindy might be having some internet difficulties. She mentioned that she had some earlier, so I'll kind of take it from here until Cindy, you just join us when you're ready.
Can you hear me now, Meredith?
I can, yes.
Okay. Well, I didn't even know, but I am
That's
getting
okay.
a message. Yeah, I am getting a message saying I'm unstable, which I don't know what to say to that.
Well, you keep taking it. If you break up again, I'll carry on.
Great. Okay. So there's some ways that you can use a person-centered approach when you're communicating. And the first one is always treat that person with respect and dignity. Use your knowledge. What do you know about that person and their likes? Do they like to communicate verbally, or do they prefer to write things down? Call the person by their preferred name. I noticed that when we put him in a memory care, a lot of the workers would refer to him as honey and sweetie. And I knew my dad would be uncomfortable with that. He was a very kind of stoic kind of guy, and he would not have appreciated people he didn't have a relationship with or didn't know calling him these names of endearment. So I just respectfully shared with them that he would prefer to be called John, and they were fine with that. So remember, you are their advocate. You need to communicate to everybody around that person what their wants and needs are. Don't talk about the person as if they're not there. Hearing is the last sense to go. So people with dementia want to feel included, and especially when the conversation is about them. Avoid correcting them and validate their feelings. A lot of times people with dementia will say things that aren't accurate. It don't make a lot of sense. Don't correct them. What difference does it make? Unless what they're talking about is dangerous to them, just go along with their thoughts and feelings, because they are just as real to them as me talking to you is real to you today. So how do we apply a person-centered approach to communication? Many people living with dementia say that others don't include them in conversations. So talk directly to that person. Make sure you speak very slowly and clearly in a very calm tone of voice. When the person responds, acknowledge what they say. Keep them engaged in that conversation. Have conversations about family and friends in your lives, including things that you've done together. Now, a word of caution here, please don't ask them, do you remember when? Because all that does is create anxiety and frustration when they can't remember. So it's our job to fill in the blanks. In other words, like for example, if I took a family picture album to Dad and we were going through the album, I would not quiz him on who this is and ask him if he remembered that. I would fill in the blanks. I would say, Dad, look at you in that tux at Sam's wedding. Look how handsome you were. And he would just smile. So we have to learn to acknowledge that they cannot remember and try not to force those things. Next, it's important to be patient and not rush the person living with dementia. Give that person time to decide what they want to say.
Hey, Don, this is going now.
So many times the person will really need that extra time. And it's almost second nature for us to try to fill in the blanks, find the word, but don't do that. Give them choices. Try not to speak for them. Instead of asking Dad, what would you like for lunch? I would give him a choice. Dad, would you like a ham sandwich or a turkey sandwich today? That's so much easier for them to come up with a response. Connect in that moment. Talk about what is happening around you, how the person is feeling right now. Listen to what they say and respond in a way that shows that you understand and you care about their feelings. That is so much more important than the reality of the situation. Just listening and acknowledging and connect with them and try not to correct them. The fourth thing, when we talk about applying a person-centered approach to communication, is try to limit as many distractions as possible. When you're having a conversation, find a quiet place to talk. Turn down the TV that's in the background. Have one-on-one conversations. It might be hard for that person to be in a conversation with several people because the ball keeps bouncing back and forth from person to person. So try to keep and have some very meaningful one-on-one conversations. And keep those conversations very simple. Maybe ask one question at a time or break down things into easy to follow requests. As much as you can, try to ask yes or no questions. Like I said, turn down that TV and put your phone away so you can focus your attention on that person. The fifth approach to a person-centered approach is nonverbal communication. And many times we can deliver a message to that person or an emotion you're trying to communicate. And there are strategies that you can use. Use positive body language and facial expressions. Use hand gestures like pointing to the object that you're speaking about. Make eye contact. Talk to that person eye level. Don't look down at them. Make sure that you can talk to them at their own physical level. And when you make that eye contact, don't stare. Just make sure it's good, healthy eye contact. So now we're going to skip a few slides you'll see on the screen, and we're going to talk about how to communicate well with others. And as Meredith is going through this, I want to share with you a story about communicating with my dad and entering his reality. I think that's the most important piece of information when it comes to communication that we can remember. They can no longer be part of our reality, so we have to enter their reality. And I'll give you a good example of this. One day I went over to see my dad. They were in assisted living at this point. And I had recently made sure that most of Dad's family and friends would contact me for the visit. Sometimes they would, sometimes they didn't. But anyway, when I walked in their apartment, Dad was so excited to see me. He had that big smile on his face. And when I would enter the room, I wouldn't quiz Dad. I would acknowledge who I am. I would say, "Hey, Dad, it's Cindy." And, sometimes he would say, "Of course I know who it is." And then other times he wouldn't. But anyway, on this particular day, I go in, tell him who I am. And he said, "I'm so glad you're here. I'm so excited to see you. You will never believe who came to see me last night." Now, I didn't think anybody had been there, but, sometimes it happened. So I said, "I don't know, Dad. Who came to visit?" And he got a big grin on his face and he said, "Your Pa." Now, Pa was my granddad who'd been gone probably 40 years. Now, I didn't correct Dad. I simply said, "Oh, wow, I wish I had been here. I would have loved to talk to him." And you see what I did? I validated his feelings. I validated his reality. And had I corrected him, he could have gone into grief because learning that his dad had passed away would have been a new thought in his head. So we want to avoid correcting and overcorrecting people and just make sure that as long as what they're saying or asking is not a threat to them, it's okay to let them think things that aren't part of our reality. Now, as a caregiver, it's one of often say when I became a caregiver for my dad, it was the most difficult job that I ever loved. But it's important to talk about your needs and the needs of the person living with dementia and communicate these needs regularly with family members, friends, healthcare professionals. And this will help you build that strong support network, which you will certainly need. So let's take a look at some tips for communicating with family, friends, and health professionals. First of all, when you are communicating with family and friends, it's important to talk about your feelings, your worries. Be open and honest, and don't be afraid to ask for help. It's okay to say what you need and let people tell you how they can help. Have those difficult conversations when you need to. Now, this can be a difficult topic to talk about because you're going to be talking about finances, disease progression, end-of-life planning, but these are important conversations. And the earlier you discuss these topics, the more likely others are to support you when the time comes for a difficult decision. Try to be patient with your family and friends. Give them time to be angry. With my family, I had to give them time to work through their denial. And I don't see that a lot when we're doing these presentations, but it's not uncommon for many family and friends to go into denial and say, you're overreacting, you're reading more into this, because they don't want to believe it's true. So allow them to work through their denial. Stay connected. Make time to check in with others on a regular basis. These conversations give you a chance to talk about other support that you may need, which can change over time. Now, as a clinician, as a therapist, we spend most of our career listening and letting people talk. And many times it's just the talking that is therapeutic, not what the person says, but whenever a person shares with you their frustration, their feelings, their anger, whatever emotion they're feeling, just voicing that gives a little bit of it away and helps them feel better. So it's not so much that having the conversation is going to result in that other person giving you answers. It's more about releasing your own feelings and anxiety. Now, to communicate well with a health team and professionals, you really need to be prepared for appointments. As a caregiver, you are their advocate, and you have to take that role very seriously and trust your instincts. If your gut is telling you that something's not quite right, then you're probably spot on. First of all, like I said earlier in the presentation, learn as much as you can about the diagnosis, because that knowledge is power. Have communication and questions and document it before you go to your healthcare provider. And don't be afraid to ask the hard questions. That's what an advocate does. Make sure you explain the details to your doctor or other healthcare professional. Be ready to share the most recent details about the person's health. No detail is too small, and keep a journal of behaviors so we can look for patterns. When you're talking to a healthcare professional, be sure to take notes. Write down what you discuss during the appointment, or ask the doctor if you can record the conversation. And most doctors will say yes, but that will help you to go back and listen to what the conversation was, but also you can then share that recording with friends and family members that might benefit from hearing that. If you don't understand something, ask them to explain it differently, or ask them to repeat something. And ask if you can have a summary of your appointment. Think about your environment. If the doctor is speaking to you in a busy waiting room, or if you're in an area that's too loud for you or the other person living with dementia, ask to be moved to a quieter, more secluded room to make it easier to communicate. I think many times people kind of shut down when they're talking to healthcare professionals. I don't know whether they feel like they might ask a question that might sound stupid, but there are no silly questions. Go ahead and ask whatever you need to. So those are just some tips on communicating with others. We also want to share with you some information about the Alzheimer's Association. Whether you're looking for additional ideas to communicate more effectively, the association is there for you. And we provide just a plethora of information and support. To include, you'll see the 24/7 helpline in the first box there. You can call and connect with a master's level clinician at any time, and they can help you sort through whatever issue that you're dealing with. They have all kinds of resources that they can share with you. And sometimes, like I said, it's just talking to that person and venting. I often tell caregivers, make sure if you're a caregiver, you have a vent buddy, somebody that you can talk to and share with all the stresses that comes from a caregiver. We offer many, many local resources. You can go online and find your chapter. There's support groups for caregivers, groups for people living with Alzheimer's and others facing the disease. Some of these groups are led by professionals and others are led by specially trained caregivers just like you. The Alzheimer's Association is a database for dementia and age-related resources. It's an online tool that can help you find programs and services in your area. Our website, easy to remember, alz.org, has free information and resources for people facing Alzheimer's and other dementia. There's information on staying safe at home, and there's just any topic at all, you can find some excellent resource. And all these resources are free, so be sure and check that out. The ALZ Navigator is another interactive online tool. You can answer questions about your situation and make a plan for you. This includes information, support, and local resources. We also offer a number of education programs, just like the one that you've attended this morning. And these programs can help you learn about the disease and various caregiving topics. We have free in-person, online, and virtual programs. So with that, I'd like to open it up for any questions that you might have.
Yes, I have a question.
Yes, ma'am.
I have a 55-year-old daughter who also has Down syndrome.
Mm-hmm.
That is just the beginning stages, showing a lot of the symptoms of Alzheimer's. And just want to know if there's anything out there that would help me navigate with her and my acceptance. I'm just having a hard time dealing with it.
Well, Bonnie, that's a lot. You got a lot on your plate, and you're doing the best thing you can right now, which is learning as much as you can about this disease. And I'm sure this is complicated by the Down syndrome. I don't know. I'm going to ask Meredith. Meredith, do you know if we have any special groups or programs that are dedicated to caregivers of a patient that has Down syndrome?
We do not in Kentucky that I know of. However, Bonnie, I'm going to put that 1-800 number, the 24/7 helpline number in the chat. Just give them a call and see, because there might be a nationwide kind of virtual support group or support system I think they would know about, since the 24/7 helpline covers the nation and not just our state. So, sorry, I don't have anything local to tell you about that I know of, but definitely give that 24/7 helpline a call and just kind of share your situation and see how they might be able to direct you to get more connection with others. Thank you for your question.
I missed the very beginning of this. I guess I got on late, maybe due to time changes. So I missed all of what the gentleman was talking about when you first started. Was there any specific like medications or anything that helped?
Bonnie, you're going to get an email with all of the slides that talks exactly about the medications. Are you in Kentucky?
Indiana.
Okay. So we can't do telehealth from Kentucky to Indiana, but if you want to put your email in the chat, myself or Sarah Hatch can get directly in contact with you after this programming.
Okay. Just put it in where it says type the message.
If you want, you can click on that and put it in, or if, you can click on just, if you
just send it
Sarah
to
Hatch.
Sarah. Yeah, to Sarah.
Yes, ma'am.
Okay. Okay. So nobody's been on there. You haven't ever had any dealings with any Down syndrome people with Alzheimer's?
I have not. But, I do know that as her mother and caregiver, you know her better than anybody else.
Oh, yeah.
So please, as Meredith said, call that number, but trust your instincts, trust your gut. Unfortunately, sometimes that's the best guidance that we have. But hopefully, when you call, you can find some resources. That's kind of a unique situation, and I'm sure there's hundreds of people across the country that are in the same boat as you are. And hopefully, when you call, you'll get some resources. Good luck, Bonnie.
Can anyone just answer this question? Is there a reason that they start sleeping a whole lot more? Because that's something she's doing. She just sleeps a lot. Is that part of Alzheimer's?
It is. It's typically seen more frequently in the latter stages. I know Dad would sleep, 20 hours a day, it felt like. It was probably closer to 15 or 16, but it was a lot. So I don't think that is unusual. But how long has your daughter had the disease?
I really probably started noticing some symptoms maybe, I don't know, 4 or 5 months ago, 6 months maybe.
Okay. Then I would certainly encourage you to check with her doctor because there could be something else other than Alzheimer's that is causing the sleep. It could be.
We've done that. We've had an MRI done. Yeah.
Yeah, the first thing that popped in my head was depression. So I don't know whether she's being treated, but sometimes depression will cause a person to want to sleep all the time.
She is on medicine for that.
Okay. Well, it sounds like you're doing all the right things, and hopefully you'll get some resources, and good luck.
Okay, thanks.
I have a question. Can you hear me?
Yes, ma'am.
My husband has dementia. He goes to the Best Friends program several days a week. But I've also started using part-time home caregivers. And I'm wondering, do caregiving people and organizations, do they use the Alzheimer's Association to do orientations with their staffs so that the home aides and the people who go into assisted living places or even independent living places where people don't need full-time care, but have home or caregiver aides. Do those aides ever get good training from, say, the Alzheimer's Society?
Can't answer that question for every organization and facility out there, but I do know as a community educator in Western Kentucky, I have spoken to many employees of facilities, many employees of caregivers. So the answer is yes, but I don't know that all agencies or organizations do that. I think that would be a wonderful screening question to ask before you engage someone, because certainly the ones that are trying to make sure the employees have the best skills available will implement, and they invite us in quite often to come and speak to employees and be part of their onboarding of new employees. So my advice is always ask that question.
Yeah, well, I have good people, but it's not a licensed agency, but there are a lot of home caregivers out there. And it seems to me that people like me, and it didn't occur to me until I was watching this presentation this morning, we ought to, if they haven't done it, we should suggest that they ask you all for some kind of orientation or education, even if it's a 1 hour, hour and a half, 2 hour program.
That's right. And Jane, if you have independent caregivers that aren't part of a larger organization like what you're referencing, you can go on our website and they can watch a lot of these training programs and get these resources. And you can even watch it with them.
Mm.
And Jane, this is Meredith. I just wanted to add, I think that right now our public policy advocate and employee in Kentucky, Mackenzie Wallace, is working to try and get some legislation passed that would require some dementia education by the folks that you're kind of talking about. I don't know all the ins and outs of what's going on in government in Frankfurt, but I know that's one thing that she is trying to work. So that's another angle. You know, we give these free presentations like Cindy does, but that's another angle, is to pass legislation to make it required. Right.
Well, however it's done. I mean, I'm lucky because I know the questions to ask, but not everybody does. And so that's a great idea. It sounds like if there's legislation proposed, somebody's paying attention to it.
Absolutely.
So that's good.
Yeah.
Thank you.
You're welcome.
Someone else had their hand up. I'm not sure who that was.
I'm sorry. Yeah, my name is Taylor Cobb. I had my hand up. I was curious, is there, I have missed some of it. My power went out, so I lost my internet, but I may have missed this. Are there any statistical research regarding the health decline in caregivers who are working with people for dementia? And because I think that a lot of, I wonder that because a lot of the the caregivers that I work with, they feel like they're alone in this. And like they feel like they're the only, there's a sense of guilt that comes on them because they don't have the patience, they don't have the I guess the mental capacity at that time to kind of deal with caregiving for someone for dementia. And so I think that if there was like statistical research that I could present to them to like prove that they are not alone in this, and it may take some of that weight of guilt off their shoulders. So I was just curious if there was ever any type of things done like that you know of.
Yeah, I've seen some research. I can't quote it, but obviously you're right on point. The stress from being a caregiver, anytime you're under a heightened state of stress, your inability to fight diseases. You develop a lot more health issues because your body is in that constant fight or flight response.
Yeah.
So I don't know, Meredith, do you know of any specific research that points to the question?
I am fast and furiously looking it up on our website because I don't, like you, Cindy, I don't want to give the wrong statistics. So I'll put it in the chat because I think I found a website that I can get you to.
Great.
Yeah, because I think that would really help a lot of my clients because even when I tell them, like, hey, you're not the only person that's experiencing this, I think they probably think May could just take that as I'm just trying to make them feel better in the moment. But there is a heavy weight of guilt that I see with people who can't mentally handle caring for someone. And so they do lose their temper quickly. They do get frustrated quickly, but they're not educated with these workshops. And a lot of people don't even know all the assistance out there. So I think that if they can that would be very interesting if we could have that and share that, because if they see like from a research data statistical, point of view that they're not alone, I think that they may be able to relax a little bit and can probably try to realize that they're not the only ones and, ease their own stuff. Because I have a person right now who's having to go to seeing a doctor because of her blood pressure. Because her blood pressure has elevated. She's an older woman caring for someone with dementia, but her body is physically declining because of all the mental stress that she's dealing with. But if she's not there to take care of him, then this person can be highly, highly exploited. So it's kind of like a situation of, dang if she do, dang if she don't. She's got to pick, the moment. So I think that, her seeing that she's not alone and the feelings that she has are not, like, there's nothing wrong with her. I think that will make her feel better. So thank you.
Right. And we need to normalize these, what people refer to as negative feelings. They're normal. I agree. If you're a caregiver, you're not only under extreme stress, but you're experiencing extreme personal grief for this person that you love.
Yeah.
I just put the link in the chat for you. So a lot of stats for you there.
So Taylor, there are 11 to 12 million Americans that provide unpaid care for people with Alzheimer's or other dementias. So your client is definitely not alone. And my presentation next is going to be talking about those resources that you were referring to.
Okay. Thank you, Ms. Regina.
This is Melva. I have a question. The two presenters so far have referred to our website. What is our website?
ALZ.org.
ALZ.org.
Meredith, can you just throw that in the chat?
Thank you.
Just did.
Okay.
Yeah. All right. Well, if we don't have any other questions, Cindy, we want to say we got one more.
Yes.
Okay.
I hate to even ask this question and don't even know if it's proper, but this is back with Bonnie with the Down syndrome daughter. Is there a length of life with this?
Well, just like with any disease, no two situations are the same. There's so many variables. If you were on the earlier presentation, you saw from the diagnosis to death was about 9 years. And that is just a benchmark. That doesn't mean it's going to be there the same for everybody. Some will be more, some could be 20 years. It's just there's no rubber stamp when it comes to the longevity of the disease. There's so many factors that play into it.
Okay.
And Bonnie, I'm actually going to send you a direct message in the chat with some links that directly talk about Alzheimer's disease and its correlation with Down syndrome. So be looking for that here shortly. So, well, And just to honor our next speaker's time, Cindy, we want to say thank you for presenting. Thank you all for your very good questions. Awesome questions. Keep it coming. Let's take a break until 11 o'clock and we'll welcome Regina Goodman. And Regina, I'll let you take it whenever you're.
Okay. Thank you so much. So I am Regina Goodman, the Caregiver Program Coordinator at the Area Agency on Aging and Independent Living. And as the Caregiver Program Coordinator, one of the most important things that we like to tell our caregivers is that it is so important that you take care of yourself first so that you can be a better caregiver to your loved one. And one of the ways that you can do that is like today, being here, learning about the disease, learning about how to communicate, and different things like that that are associated with the disease. But also, I think it's important to know about the local resources that you have that can help you take better care of yourself. So I'm just going to briefly go over these because sometimes when I get to talking, I may use acronyms and say things that you don't really understand because you're not familiar with them, and I'm just used to saying them. So when I refer to DAIL, that is the Kentucky Department of Aging and Independent Living, that is there in Frankfort. The Bluegrass Area Development District is the building where we are located at 699 Perimeter Drive. And so under the Bluegrass Area Development District, they not only have aging services, but they have workforce and community planning and GIS and things like that. So the whole broad agency is the Bluegrass Area Development District, but our focus is on the aging part. So that is the Bluegrass Area Agency on Aging and Independent Living. And that is a mouthful, and there is no way to shorten that we have come up with. So sometimes I will just say the Bluegrass Area Agency on Aging, just because it shortens it a little bit, but we do not want to leave out that we also serve our elderly population as well as people with disabilities. And so our Aging and Disability Resource Center, I will refer to a lot, but I'm probably going to call it the ADRC. So that's our Aging and Disability Resource Center. I will talk about that a little bit more in detail further along in the presentation. But with our aging programs, most of them are funded through the Older Americans Act, and that may be referred to as the OAA. Thank you, Meredith. So what is an area agency on aging and independent living? Every community in America is served by an area agency on aging. And I know that someone, I think Bonnie is from Indiana. And so in Indiana, there will also be area agencies on aging and independent living. And that elder care locator can help you find the one near you. Now, within Kentucky, there are 15. And so ours is the Bluegrass area, and we cover, and we'll go over our exact counties in a minute, but we cover 17 Fayette and then 16 surrounding counties. But there are 15 area agencies on aging around the state. And if you need help finding those, if you're in a different area, I will be happy to help you find those. And then the independent living reflects the shift towards serving younger people with disabilities in addition to our elderly population. So the Bluegrass Area Agency, it's hard to say. The Bluegrass Area Agency on Aging and Independent Living will promote and provide for the development of community-based systems of care, which include planning, access, and delivery of services, coordination of activities and programs, and advocacy on behalf and education for older persons, disabled individuals, and caregivers in the communities of the Bluegrass. So we do not provide direct care at our agency. We will make those referrals and things like that to other programs. But our building on 699 Perimeter Drive, we do not directly provide that respite and those personal care services and things like that, but we will get you to the people that do. Next slide, please, Meredith. So this is our region, the Bluegrass region. So we cover Anderson, Bourbon, Boyle, Clark, Estill, Fayette, Franklin, Garrett, Harrison, Jessamine, Lincoln, Madison, Mercer, Powell, Nicholas, Scott, and Woodford County. So that is a lot of counties that we serve. But if you happen to be outside of our region and you're on here today, we will help you find. Now, all of those 15 area agencies on aging are going to have probably similar or close to the same programs that we do. They just may execute them a little bit differently. So even though they may have the programs that I'm going to talk about that we offer, it may look a little bit different across the state. Thank you. So, and these are some of the services that we talked about that we provide. The Aging and Disability Resource Center, which, like I said, we'll talk a little bit more about. Our senior centers across the area, nutrition program, home care program, the Nursing Home Ombudsman Agency, legal services, the SHIP program, which helps with Medicare and open enrollment, health promotion and disease prevention programs, the National Family Caregiver Support Program, which I will talk about in great detail in a few minutes, Medicaid waiver, the participant-directed services, the Kentucky Caregiver Program, which is a state-funded program that helps grandparents who are raising their grandchildren by providing funds to purchase clothing, personal hygiene, school supplies. We'll talk about that a little bit more later. The Bluegrass Mental Health and Aging Coalition, and Elder Abuse Prevention. So these are all of the programs that kind of go through our agency that we are able to provide. Like I said, maybe not directly in our building, but we can get you referred to these programs. Okay. So when I talked about the Aging and Disability Resource Center, that is going to be the starting point. So any of those programs that I talked about on the previous slide, in order to be referred or to get applications or anything like that, we have to start with our Aging and Disability Resource Center. And so anything that you hear about today that you think you want to apply for or know more about, you are going to start by calling this number, and it is 866-665-7921. And that is the intake number. So what typically is going to happen, you're going to call that number. You're likely not going to speak to someone once you call it, but you are going to leave your name, best contact number, and if you know what program you are specifically calling about, that's fine. Otherwise, they will just screen you for all of the programs. So you're going to call that number, you're going to leave that information, and then you're going to wait patiently. Someone will probably not. It will probably take a few days, maybe even a week or so. Depending on what's going on, like with the holidays and things like that. It probably took a few more days for someone to get back with you, but I promise they will. So it's not necessary once you leave that number to call back day after day and say, well, I called and left a message and nobody's called me back. So just be patient and someone will call you back, I promise. And so when they do, that's when they are going to screen you for services. Now, if you do happen to miss their call, I would suggest once you've left that information, go ahead and answer your phone for the next few days, even if you don't recognize the number. And I know typically we say not to do that, but when you've left your information and you're expecting that call, I would go ahead and answer your phone just in case it's them, because that's going to, the sooner you can talk to them, the sooner that we'll be able to get services started for you. And so if you do happen to miss their call, though, which happens, people aren't always attached to their phone. So just in case you miss their call, they will leave a detailed voice message on your phone telling you who they are, why they are calling, and what number to call back. So please make sure that your voicemail is able to receive those messages. I know sometimes I'm bad about not clearing out my voicemail, so there's no room to leave another message. So again, if you are expecting that call, just make sure that you're able to receive that voicemail if you happen to miss their call. Next, please. So the elder nutrition program, so that can be received either through congregate meals, which are served at the senior centers, and you have to be 60 years of age or older, have a spouse of an individual 60 or older, have a disability, or live at home with an eligible older individual. These meals are free. If you want to give a donation, you can, but no one will be turned away based on income. Okay, and then the home delivered meals eligibility, they encourage people to do the congregate meals if you're able to, just because of the socialization of going to the senior center. And I don't know if you have been to a senior center lately, especially the one in Fayette County, and really all of our areas have really good, active senior centers. It's probably not the senior center that you remember your grandparents may be talking about. These senior centers are full of activities and programs and trips. They plan these wonderful trips that you can go on. I know that they plan going out to eat and just activities within their own centers and things like that. So the congregate meal is really encouraged just to be able to get you to that senior center and for that socialization. And so if you're able to do that, we do encourage that. If not, they do have the home delivered meal option. And so that's just a little bit of information about the senior centers, how they, again, through the Older Americans Act in 1965, they were established. So next slide, please. And so this is just some of the criteria for the senior centers. So next slide, please. And so this is the National Family Caregiver Support Program. And I believe maybe for our audience today, this may be the one that you will likely be interested in. And so when we tell caregivers to take care of themselves and how, important that is to take those breaks from your caregiving and things like that, we know how difficult that can be. And that's why we want to let you know about some of these services today. And so the National Family Caregiver Support Program is a federally funded program through the Older Americans Act that is funding to provide respite care. And through the way that we do it, like I said, it may not be the same way across the state or even in Indiana, but the way that we do this program is you're going to have $2,100 per fiscal year. Now, our fiscal year goes from July 1st to June 30th. And so we're now kind of on the back half of our fiscal year, but we still have time left. So you're going to have $2,100 from the time that you're approved until June 30th to use that respite. And you can either hire someone, or if you have a friend or family member that you know and trust to come into your home and stay with your loved one with dementia, you can do that, and we will reimburse the caregiver for that expense up to $2,100. The other option, if that sometimes people don't have that support, and so they need to rely on agencies. And so we currently contract with Independence Assistance of the Bluegrass to provide that respite. And someone asked the question earlier about the training that agencies give for their employees who are caring for people with dementia. And I can tell you that I cannot speak for all agencies, but I do know that the one that we use for this program, Independence Assistance of the Bluegrass, they do a wonderful job of training their employees in every aspect of caregiving, but especially on the dementia part. They have to do an extensive training on dementia. And so in order to be eligible for this, the caregiver can be really any age, but you have to be caring for someone 60 years of age or older. They do not have to be related, or we know that sometimes people have an early diagnosis of dementia. So it's typically 60 years of age or older, the person you're caring for. But if they have a dementia diagnosis, they can be younger than that. And so you have to be caring for someone 60 years of age or older. In addition to the respite, we have $500 for supplies. And that can be, you can use that for incontinence supplies, which could include diapers, wipes, shucks, gloves, any of those products. It can be used for if your person drinks Boost or Ensure, you can use that $500 towards the purchase of those products. You can use it for even some small medical equipment like shower benches and things like that. And again, there are two ways that you can utilize that. And that is either if you want to purchase those, say your person has a specific brand that they like, or you just order them from Amazon or whatever for the convenience. You can do that. You can purchase those items and be reimbursed for them. Or sometimes just for the convenience factor, you can use one of the agencies that we utilize, and that is Grogan's or Professional Medical Fulfillment. Both of those are mail order. Grogan's used to have a storefront in Lexington, but they no longer do. Grogan's, they do now only carry the incontinence products and the nutritional drinks. They no longer carry the equipment. So if you think that you want to utilize this program and utilize the $500 for supplies, but you don't want to purchase it yourself, you want to go through the agency, then Professional Medical Fulfillment. They are an agency. They're actually located in Alabama, but we have been using them for a few years now. We learned about them at a national conference, and they are wonderful to work with. So there are some options in utilizing the National Family Caregiver Support Program with the respite and the supplies. I will let you know that when you do, this is a question that we get a lot. So because of my audience, I'm just going to go ahead and explain it. If you do choose the reimbursement option in this program, there is a memorandum of understanding and a W-9 that comes along with that. That W-9 is a tax form. People's taxes are their business, and I am not a professional tax preparer. So I just tell people that is a required document of our finance team if you do want to be reimbursed. And that's for anyone that they are going to cut a check to. Now, you do receive a 1099 at the end of the fiscal year. In the end of the calendar year for that. If you utilize that January through December, then you will get the 1099 that goes along with that for the respite. The supplies is a little bit different story. So you do have to fill out the MOU and W-9 for that, but you will not get a 1099. And so our Kentucky Caregiver program that I mentioned is a program to help grandparents who are raising their grandchildren. And we can also, this is the state funded program. This one is income based. We can also help grandparents who are raising their grandchildren under the National Family Caregiver Support Program. You just have to be 50 years of age or older, but there are no income guidelines. In this program, there there is an income guideline. So when you go through that process and we send you the application, you do have to send in a little bit more paperwork with that. And we do have some caregivers in the program who are caring for their parents with dementia while also caring for their grandchildren. And so we do have some that can utilize both programs in that way. And so you will receive, it's $500 per child in that program. Our Medicaid waiver, participant directed services. So that the Medicaid waiver is an alternative to institutionalized care. So this is a way for your loved one to receive their services in their home instead of like a nursing home. And when you call that ADRC, that Aging and Disability Resource Center number, those people are trained to help you with this process because it can be a little bit complicated, and they can help you start the application and answer your questions as far as that goes. Okay, and that's just a little bit about the eligibility and that they will go over with you if you are interested in that. Okay, next slide, please. So this is the state health insurance program that I talked about. They can help you with your Medicare questions and that open enrollment. I know that can be challenging as well. So you can utilize that program if you have any questions about that. And there's no charge for those services. Next slide, please. So Legal Aid of the Bluegrass as well. They offer free civil legal advice and referrals for people 60 years and older and their caregivers. No assistance or advice in matters of criminal law, but they can help answer the questions for end of life planning and things like that. And there are no income restrictions, but many services are targeted to low and moderate income individuals. Okay, and so we are also involved with our we want to help prevent elder abuse. And so this is the intake number for our APS. If you have any concerns about that, this is the number that you would call to report. And some of our health promotion and evidence-based programs, I know some of the most popular ones are the Drums Alive and Bingo Size, and those a lot of times are offered at those senior centers that, like I said, are located in all of our areas. The Bluegrass Mental Health and Aging Coalition, that's another coalition that we are involved in, and they put on a wonderful conference that's held in Winchester every year. It usually happens around in June, but it is always it's always a really good day of information concerning mental health. And then our home care program is a state-funded program. It's kind of similar, I guess, to Medicaid waiver in the fact that this is how it's another program that you can possibly receive those services, that personal care and homemaking and those types of services in your home and not in an institution. Next slide, please. And those services will include homemaking, personal care, home delivered meals, respite. They do offer an escort service, chore, and minor home repair. And again, when you call that Aging and Disability Resource Center, they are going to screen you for most of these services. I'm just trying to give a little bit more detail about the programs. But when you call that number, they will screen you for a lot of these. And then this is how to connect. We do have a Facebook page where we do advertise programs like this, any type of webinar or conference or program that has to deal with dementia or any programs that we are putting on. You will find that information on our Facebook page. You can call and ask me directly any question about any of these specific programs. If I do not know the answer specifically, I will find that for you. But like I said, in order to actually be screened for services, you have to call that Aging and Disability Resource Center. That is my direct contact information. Like I said, I can answer direct questions, general questions, but in order to get you screened and actually get those services to you, you have to go through the Aging and Disability Resource Center. And I know I just gave you a ton of information, but just for the sake of time and our next presenter, did anybody have any questions?
I did, Miss Regina, but I'm gonna email you.
Okay.
Because I know that we have time, and I can always just come see you. But yeah, I'll just email it to you.
Okay. Thank you, Taylor.
I have a question. How do you prove Alzheimer's diagnosis to someone who needs to know?
How do you prove it?
Uh-huh.
Well, I don't know. Were you available for Dr. Jicha earlier?
Yes.
So I think you would start with your primary care physician.
Oh, we got the diagnosis. I'm just saying, how do I, in applying for any aid, how do I prove that?
Okay. Yes. So with the Medicaid waiver process, they will ask for a MAP 10 from the doctor, and the doctor will sign off on that with that diagnosis code.
Okay, thank you.
For my program, we don't need proof, which is the National Family Caregiver Support, the respite program. We don't ask for proof of that. But I know for some of those other programs, they will need, especially for Medicaid waiver, they'll need that document from the doctor, and the ADRC will help you get that.
Okay, thank you.
You're welcome.
This is Joanna. So if I'm in Lexington and I'm caregiving for somebody in Jefferson County, do I still go with the number you gave for agent, or do I need to reach out in Jefferson County?
So this is where it gets a little bit weird, I guess. So as the caregiver, you are in the Bluegrass District, but if the services are going to be provided in Jefferson County, that would be the KIPTA. And I forget what that stands for, Kentucky, Indiana, but I can help you. If you want to email me, I can help you with that contact there, because that's where the services are going to be provided. So that would need to come through Jefferson County, even though as the caregiver, you're in this county. Does that make sense?
So how do I get your email at the end when they send everything out? Your email will be in the presentation? Or
yes, ma'am.
Okay, thank you.
Yes, ma'am. And I'll just go ahead and put it in here now.
Regina, thank you so much for sharing all of these resources. For the sake of time, we are going to go ahead and transition into our last presentation, which is about home safety with Kelly.
Hi, everyone. My name's Kelly Parsons. I'm a social worker at Sanders Brown with Sarah Hatch, and I'm going to do a presenter view. So give me just 2 seconds to share my screen, and we will shows where it's physically located and get going. I want to show this approach. So the physical location. This gives me an exact part and a model number. So I can say Google all this to see if they got data. List of medical. No, we should have gone to all that. I apologize. Okay. Can everybody see that okay?
We can see it.
Great. Here we go. Okay. So as I said, I'm Kelly Parsons, a social worker at Sanders Brown. And today I'm going to be discussing safety in and around the home for a person diagnosed with Alzheimer's disease or another progressive form of dementia. So Alzheimer's causes a number of changes in the brain and body that affect safety. Depending on the stage of the disease, this can include judgment, so forgetting how to use household appliances like a coffee maker, sense of time and place, so getting lost on one's own street, or maybe getting the order in which events happen confused. So maybe they think an event happened before a trip or an occasion, things like that. Dementia can change the way that we view behavior. Some people can be suspicious or fearful. It can also affect safety in regards to physical abilities. So having trouble with balance. I know Dr. Jicha talked about Parkinsonian instances where somebody can't stop shaking. Senses. So experiencing change in vision, hearing, and sensitivity to temperature or depth perception. It's important to be aware of safety needs, as this will help prevent injuries and assist in the person with dementia to feel more relaxed and less overwhelmed in their space. So let's kind of pair these out and talk about them for just a few minutes. So in regards to physical abilities, you want to think about environmental changes. And really, you want to look at fall risks. So in looking at the stairwell, do the handrails, are they secure? Or if somebody fell and they needed to brace themselves, would they stay into the wall? If you can put handrails on both sides of the stairs, that's very helpful. And have the handrails the entire length of the stairs. Never place objects on the stairwell or on the stair steps. And ensure broken steps are fixed or they're not loose. Also, lighting is really important in regard to physical abilities declining because of dementia. Make sure the lights are working, and if you have light switches on the top and bottom of stairs, it's good to make sure you're not ever walking the stairs in the dark. Another thing to think about in regards to walking is the carpet or rugs. Make sure carpet is firmly attached. If there's no carpet, attach non-slip rubber treads on the stairwell. Also, you want to look at things that people can easily trip on, like clutter, stacks of newspapers, electric or telephone cords. Throw rugs can also be a tripping hazard. Within the home and safety, you want to make sure walkways are clear of any items that aren't securely in place. If you're walking around furniture, that might be a sign that it needs to move and can be a fall risk. Certainly clean up spills quickly. Both wet things and sticky things can be slippery and cause us to lose our footing. So again, in regards to physical activities, I know I talked about lighting, but truly lighting can really help a person prevent falls. You want to evaluate lighting in stairwells, hallways, and bathrooms. Fluorescent lights are the brightest and use the least amount of electricity. Have a lamp next to the bed that might be a touch lamp or a motion lamp, and put in night lights so you can see a walkway. I'm going to talk about other forms of things that items that you might purchase that might keep you safe. One of those things are motion detector motion activated night lights. They're really fantastic. Also, a thing in regards to physical activities that people might often overlook, and that is to make sure shoes and clothing are fitting properly. When your loved one is walking or standing, are they walking out of their shoes? A lot of times, sometimes as we age, we go up in shoe size, and then we hit a certain point where we then go down in shoe size. And this can be for a number of reasons, but just make sure that things are fitting well and properly as they should. All right, so another thing that I want to talk about quickly is adaptive safety equipment in the bathroom. The number attached to the slide, Kentucky Assistive Technology Services, also run what's called CARET, and that is coordinating and assisting reuse of assistive technology. This is a statewide program in Kentucky that offer local resources and adaptive equipment for people if their insurance companies won't pay for them. So just thinking about decreased physical abilities, a shower chair is an essential. Consider installing a handheld shower head, and a well-placed grab bar will be a hip saver. In the bathtub, place a nonstick mat or decals for traction. If you can, maybe see if you notice how it's kind of white on white on white. If you can put some colored decals within all of this white, it'll also help with the depth perception, and the physical ability to see sometimes can be diminished or is diminished with this disease. So that's another thing to think about as well. So another thing that dementia can affect in regards to our safety is decision and judgment making. And I know Dr. Jicha talked a little bit about just some behaviors that we might see. Some of this can be attributed to the disease. Certainly all of them can. So again, in Alzheimer's disease, the neurons lose connections as plaques and tangles accumulate. This affects judgment and decision making. A few things you want to do is set the hot water heater to 120 degrees. You can put red tape or fingernail polish on a hot water faucet to ensure that they have a physical or visual cue that the water will be hot. You also want to monitor oven use. If it's necessary, unplug the appliances or remove stove knobs. Disable the garbage disposal and put away knives for safety. Also, we're going to talk a little bit about scams, but you definitely want to monitor finances and limit the amount of cash your loved ones have access to. Gain access to checking and savings accounts. We can talk about this, but one of the things is either power of attorney or capacity in regards to being able to get attached to savings or banking accounts. Also, you want to either dispose of firearms or keep them locked in separate places as far as the firearm and the ammunition. If you can't remove both of them, remove one. You can help law enforcement, ask for law enforcement for help if needed. Excuse me. Secure power tools and lawn tools. Lock the garage and limit access to pools or hot tubs. In regards to judgment and decision making, you also want to think about medication safety. Are they taking it correctly? There's a lot of medications that can be really dangerous if taken incorrectly. So you want to monitor their medication usage. If it looks like they're starting to mess up, maybe they're running out of medication, or you open their medicine cabinet and it's overflowing with the medication, you want to help them kind of take over medication monitoring and prescribing. There's other ways to administer medication through automated pill dispensers. I'll talk about that later. You also want to make sure if you have a loved one with dementia to keep an updated medication list on hand and ensure each doctor or specialist you see has a current copy. As Dr. Jicha talked about, you want to reduce or discontinue alcohol intake and supervise the amount of someone is drinking. Tobacco use is also considered dangerous, and if you can have a person cut back or stop smoking altogether. If someone does smoke, you want to supervise them and ensure lighters or matches are secured safely. So safety and scams. This is just rampant for all people that's happening. Again, these slides will go out to you, but there are some things you can do proactively. You can certainly get account texts if you're on their bank accounts, if large amounts of cash is being taken out or deposited elsewhere. If someone is having difficulty financially with decisions or safety, you can have them get a secured credit card so it has a maximum balance. You can take away the checks, or if somebody is very adamant that they have to have their check, you can make sure it's an old check and talk to the bank about maybe getting them some safe things. I know sometimes people demand they have the car keys, and so what a family will do is file a key down so that that person still has that feeling of autonomy, but the car is not actually going to start. You can look at apps on your smartphones like No More Robo or Haya. These help screen calls. You can also get a call screener or scanner. And on this lower right-hand portion of this slide right here, you can get these from Amazon, or if you want to call a local medical equipment, durable medical equipment service center, they might have options as well. For these, you can also program numbers, so only certain numbers will come through the phone. These are for landlines. This No More Robo and Hyatt are for smartphones. There's also smartphones, if you have a Chrome or an Apple, there's a Google call screen or an Apple ask reason for calling features. These will pre-screen the call, ask what someone's calling about, and give you kind of a message of what they're calling for to help screen for scams. So just some things to be thinking about. We also have people that are scanned via snail mail. So donate to here, famous people reaching out asking for money to donate. We've had some patients and participants lose a lot of money that way. So just be aware there are other ways to scam other than phones. Email also is a huge one. Sometimes we just have people create a new email account for their loved one or monitor it daily. So another thing we want to think about in regards to Alzheimer's disease and other forms of dementia is they start to lose their sense of time and place as the disease progresses. Some people are going to have a problem with this. Some people aren't going to have a problem with this. As many of our speakers said, if you know someone with Alzheimer's disease, you know one person, the disease presents very differently for everyone. So again, it is a progressive neurodegenerative disease, and due to this progression, most persons diagnosed will become unfamiliar with their surroundings to some degree. So noticing a decline in concentration and orientation, it's important to observe your loved one's ability and modify routines as needed. Reaching out to other caregivers, medical providers, social workers, and loved one is crucial in addressing wandering behaviors and finding solutions. So these are just some definitions of wandering. One of the most concisest definitions I've heard is aimless or purposeful motor activity that causes a social problem, such as getting lost, leaving a safe environment, or intruding in inappropriate places. So as cognitive impairment declines, the risk of wandering does increase. People might be trying to, quote unquote, get to work or go see my mother. These are all types of wandering behavior. Wandering can be a result of excess boredom, excess energy, or lifelong habits. It can also be an attempt to escape crowds or noise. Excuse me. The behavior expresses an unmet psychological need such as agitation, anxiety, or a sleep disorder. So if somebody does wonder, you certainly want to have action items to keep them safe, and we'll talk about that in the next slide. But you also want to make sure your neighbors are aware. Make sure a person carries some type of ID or wears a medical bracelet. The Medic Alert ID does have a service that you can sign up for that is a 24-hour alert system, where if somebody finds your loved one, they'll call that number and they'll immediately call you. Smart 911, it's nationally known, so there should be some in your districts. However, it's not everywhere yet. But Smart 911 is really fantastic. You can kind of enter in all of your information and all of your mobile numbers. And if you do, for some reason, need to call 911, there will be, your entire household will come up, and paramedics and dispatchers will just have better information about what your household needs. All right. And then also you want to think about talking to neighbors about your loved one who wanders and getting together on smartphones. You can do this via smartphone apps. These are just a couple: Ring Neighborhoods, Nextdoor, or GroupMe are apps that you can get on that can help. You also want to place labels and garments like names and phone numbers to aid in identification. Keep a recent photograph of your loved one and a piece of unwashed clothing in a plastic bag that might be able to aid rescue workers in case they need it. So action items for safety in regards to wandering. So thinking about activities to combat wandering, utilizing community organizations for dementia-friendly events like Memory Cafe is important, and the Alzheimer's Association will have more information in regards to your local region. Becoming regulars at a favorite restaurant and developing rapport with staff can also help during meal times for your loved one. Check your local senior center for low impact classes. Be sure to check with your physician the level of activity that suits you and your loved one best. The YMC also has silver sneaker programs where membership is paid through for insurance programs. Also, you want to make sure your loved one is not hungry or needs to go to the bathroom. Thinking about safety, keep doors locked. Consider a keyed deadbolt or add another lock placed up high or down low on the door. If the person can open a lock, you may need to get a new latch or lock. Due to potential hazards they could cause if an emergency exit is needed, locked doors and doorknob covers should be only used when a caregiver is present. Use loosely fitting doorknob covers so that the cover turns instead of the actual knob. Place stop, do not enter, or closed signs on the door to avert attention of the person with Alzheimer's disease away from the door. You can also place small scenic posters to camouflage or put up a pair of window curtains or match the wallpapering to the door to camouflage the doors. Install safety devices found in hardware stores that can limit how much windows can be opened, and install announcing systems that chimes when the doors are opened. These can be found, you can do this with smart Ring cameras, or you can also do this with just magnetic door chimes that you can get at your local hardware store. You also want to make sure that you secure the yard with fencing and a locked gate. Also, in regards to visual items that might signal a need to get outside of the house, like the person's purse, their coat, hat, keys, things like that, keep that out of sight so a person won't get a visual reminder of leaving the house. So using technology to keep people safe. I know Apple Watches or Fitbits now have health monitoring capabilities, so they can monitor heart rate. I think some might monitor oxygen levels, and they can also, I think for a service, they all have fall detection risks monitoring devices. There's also medical alert systems. I know I talked about the medical alert in the earlier slide, but they're wearable devices. They have intercoms that you can install throughout the house. Alexa, Siri, and Google Echo all have the ability to call people if your loved one is able to ask it to call for help. They can also be appointment and medication reminders, grocery lists. They also can play music. This device over here, this is an automatic medication dispenser. These can be smart medication dispensers where they'll send you a text message if your loved one has not opened the container at the exact time. You can also fill it for exact openings. So if they take an AM medicine and a PM medicine, but they're different, they can take that safely with this. Let's see. Ring monitoring home systems. These also have intercoms available if you're interested in that as well. Okay, so another thing we need to talk about is driving concerns and safety. So trouble locating familiar places, trouble following directions to find new places, failing to observe traffic signals, making slow or poor decisions, becoming increasingly angry or confused when driving, poor lane control. If you've noticed they've had fender benders or been hitting curves, needing new tires, things like that. So how do I approach driving concerns? Sorry, I don't know if you can hear that, but we have a bird and it's being very loud right now. I apologize. So how do I approach driving concerns? Have a conversation with your loved one or family member. Have conversations with the doctor and plan for alternatives to driving. In regards to stopping the driving, remove keys, remove the vehicle. We've had a lot of patients tell their loved one, or a lot of patients' families tell their loved ones, the car needs to go into the mechanic for a few days. It needs to be fixed. And they just keep saying that until their loved one doesn't remember that they drive anymore. This is a very difficult, delicate task. Certainly reach out to those around you for assistance. You also can disable the car. We've had people take batteries out of the car. Driving evaluations. I know Cardinal Hill and Norton Healthcare and Louisville both do driving evaluations. UK also does, Cardinal Hill, I believe, UK has a driving evaluation. There are alternates to driving. If you are the American Red Cross and Wheel Service, there's also different counties have different transit services offered for Medicaid transportation. If you're in Fayette County or North Jessamine County, ITN of the Bluegrass is also an option for you. So just in regards to times, I'm going to keep this pretty quick, but I just do want to note in regards to Alzheimer's, it affects every part of your ability to interpret the world around you and thus your safety. Sight, there may be nothing physically wrong with your eyes of your loved one. However, our brain's ability to interpret the images may decrease, and this can cause confusion or disorientation and the ability for people to recognize familiar people or places. Smell, you want to look for spoiled foods in the refrigerator. Sometimes smell decreases or no longer exists. People lose their sense of taste with this disease, and this can affect if the person eats enough. There is also danger or confusion leading them to place hazardous items in their mouth. Let's see, touch, as with other sensitivity, depending on how severe the loss, people might not recognize if it's hot or cold. So those are just some things to think about. Again, they might get confused with things that are around them. Depth perception, again, we talked a little bit about that. Our eyesight gets a little dangerous. So other safety tips, have an emergency plan ready, check smoke detectors regularly, assess the safety of a person being home alone. Will they know what to do if there's a fire? That kind of thing. All right, thank you so much. I'm going to stop sharing and come back online. All right, any questions?
A lot of suggestions that you made were not actually on the printout. I wonder if there's
Yes,
anything we could get.
that is because our counterpart, Sarah Hatch, was going to do the talk. So those are the slides that went out. Unfortunately, the internet had other plans. So we'll make sure we get those slides out to you.
Thank you.
Of course.
In a dementia group, the first one I've been to, my husband's in the process of being diagnosed. Several people said that once you have an Alzheimer's diagnosis, you should not drive because the legal ramifications, because you have a fender bender, open up everything you own to a court or a lawsuit. Would you agree with that?
MJ said that you could leave at noon.
So,
yes, almost.
So I think it just depends on where in the disease process they are. This is a conversation that a doctor really is the one to decide on that factor, and family members. The Academy of Neurology did a few years ago, and we can put this in the chat, kind of get together with actuaries that looked at guidelines and released guidelines on dementia and driving. And one of those guidelines, I know Dr. Jicha talked about the cognitive memory and thinking test, MMSE, or mini mental status exam. And one of the guidelines is you have to have a certain score on that test in order to be safe to drive. So that's something to look at as well. I think so many things get taken away with this disease. It's really important for a person diagnosed to stay as independent as possible, but also we want to keep them as safe as possible. So one of the big questions for us is, have they ever gotten lost? And if the answer is yes, then our recommendation is to either decrease driving to where somebody is with you at all times, or to fully stop driving. But yeah, it's a difficult balance.
Tells you just basic instructions.
Are you going to put the link to that study and that information that has the score and so forth on it?
Tells you which ones here that you
Please.
are supposed to.
And I wonder if taking the driving test at Cardinal Hill
Doctor who ordered your
would help protect you from
your follow-up appointment
that kind of
on February
financial
9th,
ruination.
at 10:30. Okay.
Okay.
I'm just pulling that up now, and then I'll put it in chat.
I have a question.
Yeah, go for it, Bonnie.
Well, I'm sure I could find this out by calling of it. Something maybe you might know right offhand. Since my situation's different with having someone younger that is not a senior, she's 55, but has Down syndrome, is on Medicare and Medicaid. I was wondering about the Y membership. How do you have to be to get that silver sneakers, or do you get that if you're on Medicare?
Only Bonnie, I don't know. Regina, I saw you come off mute. Do you know?
Yeah, I was just going to say I'm not familiar with that, but
okay.
The SHIP program, I'm going to look up that number and I'll put it in the chat. They may be, since that's kind of a Medicare related issue, they may be able to help you with that. I'll put their number in the chat.
And I'm going to put the Silver Sneakers website for everybody in the chat as well.
And Silver Seekers is a Medicare benefit, so it wouldn't be through Medicaid. But I'm not sure the rest of it.
Yeah, because she's not typical age for Medicare. She is on Medicare for disability.
Disability, yeah. But if you want to call the local YMCA in your area as well, they might be able to have more information and get you enrolled.
Okay, thank you.
Sure. All right.
All right. Well, I want to thank Kelly for sharing. As she said, my internet has been unstable today, so I thank her for jumping in right at the last minute. I have been taking notes of kind of some of the general questions that have been coming up, and I will work on preparing not only when I send out the slides and the link to the recording, I will send some additional resources that I've heard that have been kind of general questions to make sure you have those connections. So we just thank you all for coming. We're so grateful for you spending this time with us, and we hope you guys have a great rest of the day, that you can stay warm. So thank you for coming.
Thank you.